So let's define what we mean by micronodular lung disease. Obviously, these are rounded opacities. Typically, they're very small, less than 3 to 5 millimeters, usually on the 2 to 3 millimeter side of that, and they are usually quite numerous. Now, a little bit about CT detection. I think that there have been a lot of support in the literature over the last 20 years for using sliding MIP reconstructions for detection of micronodular lung disease. In this case, I think you can see them pretty obvious. This is a pretty obvious case to begin with, but I'll show you a case as we go through where I thought the MIPs were really helpful. This is my protocol. I usually use about 5 millimeter thick sections and slide through them at 1 millimeter increments. And again, if I'm trying to decide whether or not there are really some little small lung nodules there, I find this technique fairly helpful. I also find coronal NPR is helpful, particularly for assessing distribution, as we'll see in a minute. I think it helps you, obviously it gives you a upper lobe, lower lobe predominant sort of picture, but it gives you an idea just how diffuse the abnormality is in terms of disease distribution. Okay, so we'll start with this case. This is a patient with loads of tiny, well-defined lung nodules. How do we approach a differential diagnosis in this case? All right, well, first and foremost, distribution is key. Identifying the distribution primarily related to the anatomy of the secondary pulmonary lobule is very helpful for constructing a differential diagnosis. 3 patterns have been described: a random or diffuse distribution, central lobular distribution, or a perilymphatic pattern. Okay, and what we're going to focus on first is the central lobular pattern of nodular opacities. Okay, so this patient has a discrete central lobular nodules. Let me just see if I can get the pointer up here. You can see them out here, all right there. Some of them about 5 millimeters from the pleura, and that's one of the characteristics of central lobular nodules. They will cluster along the core lobular bronchiole and artery, as you see here in the diagrammatic section, but they will typically not extend to pleural surfaces or extend to the interlobular septum. That's very important for differentiating this pattern from the perilymphatic pattern that we will discuss in just a moment. And again, in the left lung of this particular patient, we can see these nodules. Even in dependent portions of lung, we see that very subtle peripheral clear zone. These nodules are out there in the center of the secondary lobule, but they do not touch pleural surfaces. These are classic central lobular nodules. Now, when you identify central lobular nodules, I think it's helpful to describe some further features about them before we attempt a differential diagnosis. Are they relatively solid and discrete? Do they demonstrate a tree in bud pattern, or are they of ground glass attenuation? Because our differential will differ depending upon which of these answers we arrive at. Okay? Now, the solid and the tree and bud sort of go together to some degree, so I'll talk about them next. This patient has solid, discrete central lobular nodules. There are no additional linear opacities here to imply a tree in bud pattern. Now, what is my differential for solid central lobular nodules? I'm thinking about the pneumoconiosis, silicosis, co-workers pneumoconiosis, pulmonary Langerhans cell histiocytosis, infection, as we saw a number of cases this morning of infection manifesting with central lobular nodules, aspiration, very probably under-recognized cause for central lobular nodules, particularly in dependent portions of lung and particularly in hospitalized or otherwise debilitated patients. And then rarely you may see metastatic disease having a purely central lobular pattern. That's not really all that common in my experience, but it certainly has been described in the literature. This patient, as you might have imagined, has silicosis. Now, it would have been helpful if perhaps, as in this patient, we had more areas of conglomerate fibrosis in the upper lobes, and that would be a clue to the appropriate diagnosis. This is a patient with Langerhans cell histiocytosis, also manifesting with some central lobular nodules. Notice they're not quite as well defined as the patient with silicosis, or a little bit larger, and a few of them, perhaps right there, you can begin to appreciate some central lucencies. Notice also as we scan from apex to base, there is a paucity of nodules, particularly in the anterior portions of the lower lungs, and that's fairly characteristic of Langerhans cell histiocytosis. In a more advanced state, as in these patients, we may see larger, more discrete nodules, but we then will begin to see excavation, and we appreciate the characteristic cystic forms of pulmonary Langerhans cell histiocytosis. Now, this patient has tree and bud centrolobular nodules. Here are the nodules. Some of them are soft tissue, some of them are ground glassy, but here are the little connecting linear opacities. And it's really the connecting linear opacity along the corollabular bronchiole associated with the nodular opacity in the center of the secondary pulmonary lobule that allows us to call this particular pattern on CT. This is another patient with a tree and bud pattern. You can see it here anteriorly, here posteriorly, these clustered centrolobular nodules with the little branches resembling very much a tree as it is budding. And that is, of course, what has given rise to this particular term. Now, tree and bud opacities are typically taken to imply the presence of infection, and most of the time that will be true. Tuberculosis, non-tuberculous mycobacterial infection, some viral infections as we saw this morning, and bacterial infections, I would add, as well. But I would also emphasize aspiration, again, as a potential cause of a tree and bud pattern, particularly when it's in dependent portions of lung in patients who are hospitalized or debilitated. This patient had airway disseminated tuberculosis, and this patient was aspirating. You can see that there's actually fluid here within the central bronchi, as well as a tree and bud pattern dependent portions of the lower lobe. This case was given to me by Dr. Laura Heinemann, also demonstrating a centrolobular nodular pattern with some tree and bud component, particularly up anteriorly. This patient had an esophageal stricture. The stricture was repaired. The patient had a PEG tube placed, and you can see 6 months later, these opacities have resolved. So don't forget or overlook aspiration as a potential cause for this pattern on CT. Let's talk for a minute about ground glass centrolobular opacity. Some people would object to the use of the term nodules. That's why I put it in parentheses here, centrolobular opacities. What we're talking about is perhaps best illustrated up in this portion of the lung. You can see the secondary pulmonary lobule here with a central rounded area of ground glass attenuation, 4 to 5 millimeters in diameter. You can see some other ones that are more elongated, as you can see here, along the core lobular structures. So this is a centrolobular pattern of ground glass, or centrolobular nodular pattern of ground glass opacities, if you will. Now, when I see this pattern on CT, first and foremost, I'm thinking about HP, hypersensitivity pneumonitis. And with that Florida pattern, that's going to be the first thing on my differential diagnosis. There are other things, other forms of bronchiolitis, respiratory bronchiolitis, some infections, as we saw this morning. The adenocarcinoma, or the tumor formerly known as bronchoalveolar cell carcinoma, adenocarcinoma spreading throughout the airways, may manifest with this pattern. Organizing pneumonia, cellular NSIP, and sometimes edema and vasculitis. But when it's as florid as in this particular case, we really want to think about HP in the differential diagnosis, and in fact, this patient had bird fancier's lung. It's another case talked about earlier today. This is another case of HP. This would also demonstrate some centrolobular ground glass nodular opacities anteriorly, some more broader areas of ground glass. But a characteristic feature of HP on expiratory exams, we see areas of expiratory air trapping in this patient who had recently purchased a hot tub and stored it indoors, and this is a case of hot tub lub, which Dr. Hartman mentioned this morning, secondary to inhaled mycobacterial organisms. It's a patient with respiratory bronchiolitis, and it's hard to project. I think David showed a really nice example earlier. There's probably one of those centrolobular ground glass opacities there. In this particular case, I found the MIPS really helpful because I just wasn't sure based on the individual axial sections. But as this runs through, you just get the overall sense that there are these little ground glass attenuation opacities within the center of the secondary pulmonary lobules. It's very subtle. And again, I think the MIPS here help in this patient who was a very heavy smoker but was otherwise asymptomatic. Patient with an adenocarcinoma in the left upper lung, and you can see endobronchial spread of infection here with centrolobular ground glass and to some degree more solid opacities related to spread of tumor within the air spaces. Okay, let's talk about the perilymphatic pattern just for a minute. Now, just by way of review, the lymphatics invest virtually all portions of the secondary lobules. We think about them as being very peribronchovascular, as in this particular example, but as we will see, there are also lymphatics in the interlobular septa and in the subpleural connective tissues as well. But characteristically, perilymphatic nodules will be seen along bronchovascular bundles, and you can see that perhaps better on this coronal reformatted image as these nodules ramify out from the hyla along the bronchovascular bundles. Now, as I mentioned, they may also be seen along the interlobular septa, but most characteristically is the location along the subpleural connective tissues and touching the pleura. So when you see nodular opacities adjacent to the pleura, as we see here, and on the coronal views along the margin of the lung, as you can see here, that implies a perilymphatic pattern of disease. Now, perilymphatic nodules are usually, in our experience, going to be due to sarcoidosis, and that accounts for the majority of cases. Lymphangitic carcinomatosis also can produce this pattern, and between the two of those, that is the vast majority of cases of perilymphatic nodules that we encounter on a daily basis. Other things that are occasionally reported to result in a perilymphatic pattern include pneumoconiosis, lymphocytic interstitial pneumonia, amyloidosis, and I'm sure we could come up around the room with a host of others, but usually it's going to be sarcoid or lymphangitic metastases. This was a patient with sarcoid, which will be discussed in more detail in the next talk. This is a patient with lymphangitic carcinomatosis in the right lower lobe. Here's the tumor in the right hilum, subcarinal nodes. What I want you to notice is the nodular opacities along the pleural surface, along the septa, and the thickening along the bronchovascular bundles. A perilymphatic pattern of spread here from the hilar tumor into the lung parenchyma itself. Here it is in the right lower lobe. Notice the nodular thickening along the wall of the bronchi. You have lymphatics there. You've got a perilymphatic pattern of abnormality. Here on a coronal, or actually sort of semi-sagittal MPR, we can see nodularity actually along the pulmonary veins, and on this volume rendered image, I thought it showed up very nicely the nodules along the pulmonary vein as well in this patient with lymphangitic carcinomatosis and a perivascular pattern. Okay, let's finish up with random nodules. And as the name implies, random nodularity means that you've got nodules virtually everywhere. Looks centrolobular, looks a little bit perilymphatic, but it's uniform and diffuse. Top to bottom, axial slices here, coronal view here. This is just chock-a-block full of small lung nodules. A classic random pattern of nodularity, or miliary pattern, if you will, particularly to use a chest radiographic term. Now, random nodules are frequently due to disseminated infection, as you know, miliary tuberculosis, histoplasmosis, other fungal infections, as were discussed earlier today, of patients who have a truly result in a miliary pattern or a random pattern, if you will, on CT. And between the two of these, that accounts for the vast majority of patients who have a truly random pattern of nodularity on high-resolution CT. Other things we might want to consider: metastatic disease occasionally. That wasn't supposed to come up. Silicosis, co-workers pneumoconiosis, and Langerhans-Cell histiocytosis, excuse me, has been described as having a random pattern, but primarily it's going to be disseminated infection or sarcoidosis. This patient actually had disseminated histoplasmosis. They were mildly immunosuppressed, I think related to a renal transplant. Okay. So in summary, distribution of micronodular pattern, of course, is very important. The first thing you want to do is identify whether it's primarily centrolobular, perilymphatic, or random in distribution. If it's centrolobular, we may subdivide it into solid and a subset of solid nodules, tree and bud opacities, and then ground glass central lobular opacities, and construct our differential diagnosis based upon those particular patterns.